Hey, hi everyone. My name's Laura Ehrenberger. I'm the PGY2ID PharmC resident at Ruby, and I'll be presenting a brief presentation on oral cephalosporin use in bone and joint infections. So here are some objectives for the presentation today, but we will talk about data supporting the use of oral antimicrobial therapy in bone and joint infections, and then more specifically discuss the literature surrounding dosing of oral cephalosporin therapy in bone and joint infections. So first, just as a background to talk about oral antibiotic use in general for bone and joint infections. So as a brief background, we know that bone and joint infection treatment requires a multidisciplinary team approach and typically is approached through surgical intervention and also medical management. So historically, data supports the use of IV antimicrobial therapy for extended durations, like 6 weeks. However, we do know that there are benefits of oral antibiotics, and we'll talk about the use of oral antimicrobials throughout the presentation today. So what do the guidelines recommend in terms of oral antibiotics for bone and joint infections? I have the 2013 IDSA guidelines for the management of prosthetic joint infections on the left, and it splits it into the type of microorganism. So for Staphylococcus infections with retained hardware, the guidelines note starting off with IV therapy with rifampin, and then switching to oral therapy plus rifampin. And for other pathogens, it does say that you could do IV or highly bioavailable oral antibiotics for a 4 to 6 week duration. And similarly, the 2015 IDSA guidelines for native vertebral osteo also note that highly bioavailable oral antimicrobial therapy is an option for extended duration. So as you can see, both guidelines do mention the use of oral antimicrobial therapy. So we have a few different considerations for oral therapy and when we can appropriately use them in our patients. So patients have to be clinically stable, have adequate source control, and obviously a functioning GI tract and the ability to take oral meds. Patients also have to, of course, have an available regimen for the pathogen that's isolated. And then most importantly, patients have to be willing to take their medication. So they have to stay adherent to their oral therapies. So just to mention one trial that looked at oral antimicrobial therapy for bone and joint infections, the OVIVA trial in 2019, looked at about 1,000 patients, adult patients with bone and joint infections randomized to IV or oral antimicrobial therapy, so about 500 in each arm. And they looked at a primary outcome of treatment failure within 1 year. And as you can see, there were about 14% of patients in the IV group that experienced treatment failure as compared to 13% in the oral group. So the conclusion of this trial was oral antimicrobial therapy was non-inferior to IV therapy. Looking at the OVIVA trial in a little bit more in depth and the different regimens that they used, you can see in the chart here the oral agents that were used and the percentage of patients who were randomized to these arms. So the majority of patients were treated with fluoroquinolone therapy. You can see about 15% received a penicillin. So there were some patients who received beta-lactams. However, there isn't really many patients, or there actually aren't any patients where the trial noted that they were treated with oral cephalosporins. So this is definitely a gap in literature, and my presentation will kind of focus on these oral cephalosporins and how we can use them appropriately for bone and joint. So just as a quick learning assessment question, which of the following statements about bone and joint infections is supported by the OVIVA trial? Is it oral antimicrobial therapy is associated with increased rates of adverse drug reactions as compared to IV therapy? B, most patients in the oral arm were treated with 6 weeks of beta-lactam monotherapy. C, oral antibiotic therapy was non-inferior to IV therapy with regard to treatment failure at 1 year. Or D, patients treated with IV therapy were treated for significantly shorter as compared to patients with oral therapy. Okay, seeing some C's, which is correct. So oral therapy was not inferior to IV therapy in the trial. So next, jumping into our use of oral cephalosporins for bone and joint infections. To quickly touch on the pharmacokinetics of beta-lactams, we know that for beta-lactams, we want to maximize the time above the MIC. And for penicillins and cephalosporins, the target time above the MIC to maintain bacterial killing is slightly different. So for cephalosporins, it's a bit higher at around 60 to 70% as compared to penicillins. And for beta-lactam antibiotics in more serious infections, we can definitely optimize the dose and the frequency to make sure that we hit these pharmacokinetic parameters so that the antibiotic will be effective. So when I talk about the dosing of different beta-lactams, you'll notice the dose is higher and the frequency is higher to maintain those pharmacokinetic parameters. I wanted to talk about the oral bioavailability of some of our cephalosporins. So that I have them listed here on the left with their bioavailability on the right. As you can see, for our first generation cephalosporins for cephalexin and cefadroxil, they have very high bioavailability, above 90%. And for our third generation cephalosporins, you can see cefdinir is the lowest, only at about 21 to 25%. And then whenever we look at the likelihood of pharmacokinetic target attainment, there are a few that have a relatively low likelihood of maintaining that pharmacokinetic target. So cefuroxime, cefprozil, and cefdinir are not preferred options because of this reason. So as you compare cefpodoxime to cefdinir, cefpodoxime would be the more preferred third generation cephalosporin just because it has an increased oral bioavailability and a higher likelihood of attaining that PK target. So now looking at beta-lactam bone and joint penetrations specifically, many penetrate bone at levels about 5 to 20% of serum, but that number isn't really well reported. But other data suggest that beta-lactams reach concentrations that do exceed the MIC breakpoint. So there's definitely varying literature out there. A lot of times they don't necessarily report the specific PK data and the level of bone penetration, which makes it really hard to extrapolate it to some of our other cephalosporins. There's definitely limitations in the data, so there's differences in bone compartment distribution of the antibiotics, and we don't necessarily know which sites of bone pathogens are found, so that also makes it more complicated. And then in addition to that, we don't necessarily know how the different levels of bone penetration of antimicrobials actually correlate to clinical outcomes. So I'll talk about just a few trials that looked at cephalosporin dosing and how that kind of compared to clinical outcomes. The first study is antibiotic treatment of vertebral osteo caused by MSSA, and the study focused on oral beta-lactam. So it included about 100 patients who all were treated with at least one parenteral antibiotic, and then 70 of those were followed up with oral antimicrobial therapy. And the purpose of the study really just wanted to characterize the types of regimens or the combinations that they were using, and then treatment outcomes after the oral beta-lactam switch. So here are the outcomes of the trial. So I'll try to break this table down for you, really focusing on the treatment success there on the bottom. But as you can see, about 13 patients received IV therapy alone, and then the remaining patients were switched to an oral beta-lactam at either 2 to 4, or 4 to 6 weeks. And as you can see in the bottom row with the treatment success rate, they were pretty similar between groups. And the study didn't find a statistically significant difference in treatment success compared to patients who received the IV therapy alone, as compared to patients treated with oral beta-lactam therapy. However, this study was kind of lacking in that it didn't necessarily characterize or define all of the oral beta-lactams that they used in the trial. They did note that a lot of patients had cephalosporin regimens, however, didn't actually know what those were. So there's definitely a gap in literature there. There's another study that looked at first generation cephalosporins, specifically in children for acute hematogenous osteo, so about 60 patients total. And this was a retrospective cohort study in which patients received cephalexin or cefadroxil. It was performed, like I said, in pediatric patients, but they did note specific dosing caps. So for cephalexin, the max dose patients could receive would be the 1 gram 4 times per day, and for cefadroxil, it was a maximum of 1 gram twice per day, which is dosing we see or use in adults. And they only found one episode of treatment failure in the cephalexin group, but no statistically significant differences in adverse drug reactions between them. So this study concluded that the use of first-generation cephalosporins taken orally were shown to be successful treatment options after about 3 weeks of IV therapy. And then the last study that I wanted to touch on looked at oral cephalexin and MSSA-induced bacteremic vertebral osteo. It was a relatively small study at only about 15 patients total, but patients were treated with a short course of IV therapy and then were switched to either cephalexin or amoxicillin. As you can see, the dose in this study was slightly different than the previous study, so they used a lower dose here of only about 1,500 to 2 grams per day. They found an 87% treatment success in the cephalexin arm. So this study concluded that oral step down to cephalexin would be a reasonable option after an initial 3-week period of IV therapy. So with all that to say, just going back to the guideline recommendations quickly, the 2013 prosthetic joint infection guidelines don't comment on cephalosporin dosing for treatment of this infection, although they do note chronic antimicrobial suppression dosing, which I've listed there on the left in that table. For native vertebral osteo, it actually notes that oral beta-lactams shouldn't be used for initial treatment because of their low oral bioavailability, and it also doesn't comment on cephalosporin dosing for treatment. So because neither guideline kind of mentions the appropriate dosing for oral cephalosporins, we do have to extrapolate from the data that we currently have. So for key takeaways, I had noted the varying doses that were reported in the literature, as well as the lack of trials that directly compare dosing strategies between different cephalosporins. Here is what our internal guidance recommends in patients with normal renal function. So patients can be treated with cephalexin, a gram every 6 hours, cefadroxil, 1 gram every 12 hours, and then the recommended dose for cefpodoxime is 400 milligrams every 12 hours. And this just goes back to definitely making sure we achieve the appropriate time above the MIC and we maximize both the dose and the frequency of the antimicrobial that we're using. So to wrap things up with a second question, which of the following represents an appropriate oral antimicrobial regimen for the treatment of an MSSA osteomyelitis? A, cefadroxil a gram every 24 hours. B, cefadroxil 500 milligrams every 12 hours. C, cephalexin a gram every 6 hours. Or D, cephalexin 500 milligrams every 12 hours.
We have some responses for
Okay, I'm
C.
seeing some C's, which is correct. So overall, in conclusion, recent data supports the use of oral antibiotic therapy for bone and joint infections, and there is overall varying pharmacokinetic and pharmacodynamic data on beta-lactams for bone and joint bone penetration specifically, which might not correlate to their clinical outcomes. So I think more robust trials are needed on oral cephalosporin dosing, specifically in bone and joint infection, to kind of identify the most or the best treatment regimen for these patients. And that is all I have in case anybody has any questions for me.
All right, thank you so much, Laura, for sharing that with the group. If it is all right with everyone, we will go ahead and transition over to our case presentations. We do have three. Two of them are from Jacob, and then Joy, we have one from you as well. Jacob, would you like to start out?
Sure.
All right. Is it okay if I record them?
Yeah, it's fine.
Okay. Let me share.
Both my cases are with MRSA and endocarditis that are slightly different. I switch over to pill antibiotics quite frequently, especially more than my other colleagues around here. But endocarditis is still one area where I'm still not entirely sure where the best time to do it. So we have a 38-year-old female history of IVDU who presented with shortness of breath and chest pain, had blood culture positive in 3 sets on May 3rd for MRSA, repeat blood cultures. A couple days later were positive as well. Final cultures were negative on May the 8th. TT showed tricuspid valve vegetation. Valves were not well visualized. They did not comment on the size. Mentioned mild transvalvular regurgitation. Had a CT add-on culture, which was negative, and had CT thoracic cervical, which showed really nothing acute. It had CTA chest, which showed findings most likely represent multifocal pneumonia. Was initially on vancomycin, but then was briefly on ceftaroline daptomycin until blood cultures cleared and back on vancomycin monotherapy. Cardiology was consulted and stated no T indicated at this time unlikely to change the clinical course. Of note, it had fever from 5.2 until 5.6, and that is when the still positive blood culture. So basically, once the blood culture is cleared, the fever cleared as well. So my question now, she's doing great today. Her biggest thing was having some thoracic chest pain, which is mainly resolved. No other complaints, no concern for um, osteomyelitis or lumbar abscess or any foci anywhere else. So my question is, considering this patient had prolonged bacteremia and OT, would you consider transition to PO antibiotics, basically?
Jacob, I can talk for our experience here, from our experience here. Would be comfortable with oral antibiotics with transition to linezolid. And here we've been transitioning once blood cultures are negative at 72 hours. And then plan for a 4-week course based on CRP normalization with possible 4 to 6 weeks.
So the lack of TE and the prolonged fever, blood cultures doesn't really matter or doesn't come into consideration for you.
No, I would still feel comfortable transitioning. And I think the fact that she did clear, on the 8th, would feel comfortable without the TE.
I think the TEE or the echo studies genuinely are more to help identify those patients with endocarditis that need surgical intervention. If this patient clinical course is more consistent with a right-sided endocarditis with septic emboli to the lungs because of injection drug use, then I think you have enough information once the bacteremia is cleared and the patient's hemodynamically stable that there probably is no need for valvular surgery. We have seen a few patients with very prolonged bacteremia going on for up to 10 days, and sometimes they have a very large tricuspid valve vegetation, and they've needed surgery for source control. Here, it seems like source control is not as big an issue. I was interested in the dual antibiotic up front with the ceftaroline. Was that ID or was that the team starting before calling ID?
Oh no, that was me. I do it when if they have repeat blood cultures are positive, I switch very quickly to dual therapy.
Got it. Got it.
Awesome. No, that makes sense. Again, it's I know before I left WVU, we weren't doing too much pill for endocarditis. So like again, osteo, intraabdominal, all these other stuff I'm more comfortable with. So I appreciate it. So one follow-up question is, makes sense for linezolid. And then what if it was a different organism, mainly like strep or enterococcus, how would that change your recommendations?
Not for strep, but Enterococcus is, I think, a different organism altogether. That one's a little more challenging. I think in general for native valve endocarditis with Enterococcus, I would still want to use combination therapy, preferentially with an aminoglycoside if I can, or at least with ceftriaxone, ceftriaxone, maybe at least for the first 2 to 3 weeks. I don't feel as comfortable transitioning to the oral regimen with Enterococcus. I'm not sure if others feel more comfortable.
Is that due to some studies showing differently, or?
Yeah, so for me, the biology of Enterococcus is that it's a bug where a single antibiotic tends not to be cidal if you're treating endocarditis by default. So drug of choice, ampicillin. Yes, in the urine, no problems treating Enterococcus with ampicillin or amoxicillin. You don't need a second agent. But when you're dealing with biofilms and vegetations, Enterococcus, the ampicillin that was cidal for the urine is no longer a cidal antibiotic, and you need a second antibiotic. So that literature on the combination of beta-lactam plus aminoglycoside for Enterococcus is pretty robust. It's the combination that is cidal. I think one of the reasons you might have seen that we weren't as comfortable with the oral transition is the patient population has changed. A lot of the endocarditis we've seen is really in the injection drug using patient population with fewer comorbid conditions. And then the general shift with the OVIVA and POET trials from 2019, essentially making it a little more comfortable for us. So you're right. I think the trend is more recent than in the past.
Yeah, that makes sense. Appreciate it.
I was just gonna say for the strep, depending on allergies and things like that, other options if you use moxicillin, the 1 gram PID, or even a quinolone like levofloxacin for once daily dosing, if needed, 750 milligrams daily.
All right. Well, on the, like I said, notice of endocarditis, this is slightly more complicated, I guess. 27-year-old female, probably substance abuse, comes in with a variety of symptoms. Blood cultures again positive for MRSA, this time on the 30th. And then repeat blood cultures positive on May the 2nd, negative on the 5th, was subsequently, or was intubated on the 5th. TTE showed mass present on the septal leaf consistent with vegetation. And then TE showed very large 2.8 by 2.8 centimeter vegetation on the anterior leaflet and septate leaflet extending from arterial surface to subvalvular structures with multiple large and highly mobile components. Also noted a 2.5 by 1.2 centimeter highly mobile subvalvular vegetation. It's not completely exclude valvular perforation. She didn't really act like a perf. Mitral valve 0.8 by 0.6 centimeter vegetation on the surface. This time had tricuspid and mitral valve as well. CTA showed multifocal lung opacities, bilateral pleural effusions, and infarct on the spleen. This patient did undergo an angiovac on the 8th. Cultures were pending, but actually when I sent this, but they're actually negative. Was on vanc, and once again, daptosafterline for a brief time, then back on vancomycin. And then patient is still currently intubated. So the big difference to this one, obviously, is that multiple vegetations, surgeries on board, no plans for intervention for her. So obviously, probably not while still intubated, but again, the same general question is if everything's improving in her regards, would you consider transition to PO this time with having these specific TE findings? And with the surgery, the angiovac.
With the angiovac, was that on the tricuspid valve? Did they try to target that big vegetation or?
I do not have it in front of me, but I'm 99% sure, yes.
And from an ID perspective, would you call this partial source control?
Yes, that's what I was thinking with the multiple vegetations present and the angiovac. Like I said, clinically improving, except for it has been febrile recently. I didn't see it today, but overall was improving.
Still feel comfortable transitioning. Linezolid offers good lung penetration as well. The question is with the partial source control, on either regimen, how will she do? And some of these patients say patient's going to be here a little bit longer anyway in the hospital, still intubated. We've been doing, say, a 7-day course of an IV regimen and then transitioning a little bit later. So instead of the 72-hour mark, maybe waiting 7 days as an option.
I like the fact that you presented both cases in parallel. So the first case was more consistent with the right-sided endocarditis with septic PE, quicker clearance of bacteremia. This one is both right and left-sided endocarditis with emboli to lungs and systemic circulation, and a slightly sicker patient population with partial source control. My own approach to patients like this would be, instead of the 72-hour de-escalate, maybe go for a week of the antibiotics intravenously, let them come off the vent, let them start taking oral nutrition and things like that, and then transition. But I would be comfortable at, say, by the 7th day, if they're doing well, to transition to linezolid.
Gotcha. Because the previous patient, I forget the size, but they technically didn't have, or are you considering source control that the culture's cleared on the previous patients?
Yeah, so right-sided endocarditis with vegetations to the lung, embolizing to the lungs, is kind of source control in the sense that it's gone away from the heart valve and it's now to the lungs. And now you have a good antibiotic that has good lung penetration. So it's an odd way to think of it, but that's one way to think of it.
Okay. That makes sense. I appreciate it. Again, for both of them, still transitioning after just less than a week or around a week is still pretty novel, at least around here. So it's good to get your feedback.
With daptoceftaroline. So I'm sorry, Jacob, what's your experience with daptoceftaroline? On average, once you use dual antibiotics, how long are you seeing persistent bacteremia?
Thankfully, I really haven't seen persistent bacteremia after starting. It usually clears pretty quickly. Whether it was already going to clear anyway, that's up for debate, but I really haven't seen persistent that I can recall.
And are you usually transitioning these patients from vanc to daptoceftaroline?
Yes. And then back to vanc once they clear. Assuming kidney function and all that good stuff.
Jacob, it's really good case to have the 2 different presentations.
Yes, thank you for presenting this, Jacob. All right, Joy, and now I have your case up.
The bone and joint case. So Patient's a 54-year-old male, medical history of uncontrolled diabetes with a hemoglobin A1C over 14%. Had a prior diabetic left foot infection, had a second toe amputation in February of this year. Then cultures actually grew Streptococcus agalactiae and MSSA. Peripheral arterial disease, tobacco use disorder. Presented Reynolds Memorial Hospital end of April to beginning of May with a right shoulder draining abscess. And he actually reported having pain in his right shoulder for a few months. Blood cultures were negative and had a superficial wound culture that grew MSSA and Streptococcus agalactiae. And at the time we saw him, the staph culture was actually awaiting susceptibility testing. Had a CT of the right shoulder that showed swelling and concern for, or soft tissue swelling and concern for acromioclavicular joint infection. Patient underwent right shoulder abscess and acromioclavicular joint irrigation and debridement on May 1st. Operative cultures were still pending at the time of hospital discharge, but it ended up growing Streptococcus agalactiae, so group B strep, and Staphylococcus epidermidis. And just a little bit of social history there, just from Moundsville. Again, history of smoking, no significant drug use. For physical exam, you can scroll down, actually, Kelly, a little bit and just show the pictures that are, just, you can stop right there, go up just a little bit. Thanks. So this is a picture of the patient's shoulder, the draining abscess that was present when he presented. And then a picture from his CT scanner coronal view that shows the abscess there overlying the AC joint. So pretty impressive imaging and physical exam findings. Go back up. So for physical exam, this is actually a patient that was evaluated through our COPAD ID eConsult program or IT Gold service, but was afebrile, and then physical exam taken from the charts, irregular rate and rhythm, lungs clear, alert and oriented, and we saw the photograph of his shoulder. His lab, so white blood cell count maximum was about 11,800, and then CRP was mildly elevated between 25 and 30, and sedimentation rate about 40. And then his microbiology, we already talked about his superficial wound culture with MSSA and group B strep, blood cultures negative, MRSA screen negative, and operative cultures. Had a Streptococcus agalactiae and a staph epidermidis. Imaging we discussed as well. I do have included here, he had a post-operative radiograph that just showed post-operative changes that showed debridement of the joint, including resection of the distal clavicle, and then surgical drains in place. The point here is good source control through surgery. For his medications, mainly medications for his diabetes, and then his antimicrobial allergies were significant for anaphylaxis to penicillins. So you can stop there and just kind of how would we summarize this case? Would you consider this a bone and joint infection, or?
I guess I'd say it's a 50-something-year-old male with uncontrolled diabetes with penicillin allergy presented with the right shoulder abscess, staph post source control, in which intraop culture negative, but superficial cultures growing. Strep, Eclectiae, staph, epidermidis, the negative blood cultures. Don't know what antibiotics are around beforehand. I might have picture how long they're on it before.
Yeah, good. Really good. So yeah, he was on, I think, just empirical thinking Cephalosporin, or was actually transitioned. I can share what we did for him to linazolid preoperatively at the time of our consult for better skin soft tissue coverage. And operative cultures ended up being positive as well, but really good summary. So just a 54-year-old male with uncontrolled diabetes, admitted with right shoulder abscess or carbuncle with underlying acromion clavicular joint septic arthritis, and now status post source control with INT. Perfect, Jacob. Thank you. So we feel comfortable with oral antibiotics, in this case, and then, how would you treat now that we have his operative culture or superficial culture with susceptibility testing and operative culture results in the setting of the penicillin allergy?
With the joint infected, I'd probably do, assuming the staph epi was sensitive, cefadroxil for 3 weeks, about 3 weeks, all CRP.
Maybe pharmacy colleagues can chime in a little bit in terms of for patients with, suppose that's true penicillin anaphylaxis, your comfort level with using cephalosporins.
We knew it was a true penicillin allergy, we would stay away from first generation cephalosporins, like cefadroxil or cephalexin, because the side chains are pretty similar or similar enough. This is the amoxicillin, right? Anyone else? Think if it was another type of allergy other than anaphylaxis. In a lot of cases, we would use it and comfortable. In this particular patient, his staph epi ended up being resistant to oxacillin, but probably wasn't the primary pathogen in his case. Charged with linezolid. Transitioned originally from vancomycin to linezolid preoperatively, as I mentioned. Plan to complete 3 to 4 weeks postoperatively, using CRP as a guide, with monitoring through our COPAT program. He did have COPAT labs obtained soon after discharge that showed his CRP had quickly normalized, came down to about 5 or 6. And then he was contacted through our COPAT program and doing well clinically, and he's scheduled for a follow-up at the end of the month. So we're thinking he's due for another set of COPAT labs, but assuming that CRP again looks good, to shorten him to a 3-week course. And that's because of the good source control. That's why we're comfortable with the shorter duration.
I was struck in Laura's presentation as well that traditionally diseases that we were talking about treating for 6 weeks now have like at least 4 to 6 weeks. Here we've been using CRP normalization as a comfort level of earlier and shorter duration, or earlier termination of antibiotics and shorter duration. Do you use biomarkers or just go clinically? For example, Jacob, you said 3 weeks on this patient. Would anything have swayed you to go longer?
No, CRP and how they're doing clinically.
Okay.
All right. Does anyone else have anything they would like to add or discuss today while we're together? Y'all are a very quiet bunch.
Laura,
All right.
I was going to say, Laura, we appreciated your presentation on, very good job. And on using the beta lactams, especially in the COPAT program here in our COPAT trial, we use a lot of cefadroxil. And then, cephalexin is the alternative inpatient or at facilities where patients go when it's not on formulary. And patients have done very, very well. So interesting to know that literature gap, and maybe we can take that and address that moving forward in the future, some of our patients.
Yeah, for sure. Thank you.